For us, this was such a powerful process because we learned I would say we learned 3 crucial lessons. Should I tell you the 3 lessons? We might have thought that this was about a specific disease. We might have thought that this was about malaria, but for our patients, this is not about malaria. This is not about a specific disease. You see in both of the passages we looked at, Maimuna and Ramata, neither of them mentioned a diagnosis. Each of the most prominent barriers that our patients brought up through this process were cross-cutting, did not depend on the illness. The cost barriers, the geographic barriers, the gender inequality barriers. We found that our patients were facing barriers that were cross-cutting. And so, although so much of global health is organized around these vertical disease-specific programs, we realized that by defining the problem as malaria, we had just gotten the problem wrong altogether from our patient's perspective. That's both a challenge, right? Because we have to get out of our framework, get out of our way of seeing things. That's a big challenge, but it also is an enormous opportunity. What if by removing given barriers to care, we could improve care for malaria and pneumonia and diarrheal disease all at the same time? Our patients just blew open this whole opportunity we had no idea was there. I can say in every narrative that we looked at, there were multiple barriers on this path to care. Why is that important? It's important because often with global health interventions, we focus down to doing one very specific thing. We might have even correctly selected a barrier that is important, but if we just remove one barrier along the path to care, we might actually see no effect. If we're looking at that road, let's take the example of free malaria medication, and we say, oh, look, on our barrier map, the cost of medicine was one of the barriers. But then we look at it and say, oh, if you just remove the fee for that medication, there are also the other medications that they talked about. There's also the cost of getting to the clinic. There's also the geographic distance to the health center. There's also the gender inequality. And so we've removed one roadblock on the road, but there are other roadblocks along the road, and suddenly it becomes crystal clear why, despite years of providing free artemisinin-based combination therapy at clinics across the country, we've seen rates of timely effective malaria treatment not budge at all. So, all right, cost isn't the right problem here, and we would draw the wrong conclusion, right? If we look at our barrier map, we see this cost of this malaria medication may very well be one of the most important things that we could remove, but it may be necessary but not sufficient to get the impact we're looking for. We may have done something right and still see no impact. And if we're going to serve our patients, we're going to see big impact for our patients, we're going to have to think in terms of those multiple barriers. So Mali's health system currently, if you need to get care, you have to pay for it out of pocket on the spot. As you call it, a user fee-based healthcare system. That provokes these conversations between Maimuna and Ramata and their husbands, right? In which their husbands make statements about their ability to pay for the care. And Maimuna even anticipates the household's ability to pay for the care and the consequences of paying those fees, right? And so we see how the cost of care can actually reinforce gender inequality. If in a given household, the father controls the pocketbook, controls household finances, and you need to pay fees in order to access care through the government system, then the existence of those fees may actually reinforce the role of gender inequality and the unequal power dynamics in terms of who gets to make a decision about seeking care for a child outside of the home. So that's one example, and we could draw many arrows, right, between these different barriers. We start to understand how these barriers can actually reinforce each other. So that's a challenge, right? But it's also an opportunity, because that means that as we start to remove these barriers, the remaining barriers become more vulnerable. If we remove user fees, that makes it potentially more feasible to overcome the challenges of gender inequality. That was the third lesson we learned, is that these barriers on the path to care can reinforce each other, and removing these barriers on the path to care may have effects on other important barriers along the way.